The doctor is in. We're here for a special Sunday episode. We're glad that you're here with us today. And with a new doctor friend of ours, Dr. Bronstein, and we're going to talk about my favorite topic for the doctor is in clinical trials. So, Dr. Bronstein, let's introduce yourself and just give people some background on you, and then we'll kind of dig into this topic and how we met and
Sure.
why we're talking
Absolutely.
about this.
Absolutely. My pleasure. So my name's Leor Bronstein. I'm a radiation oncologist at Memorial Sloan Kettering. And what that means is I know many people on this call will be very familiar with what that means. But for those not familiar, a radiation oncologist uses radiation in the treatment of cancer and some other benign conditions. So it's a third line of treatment in addition to the chemotherapy that's delivered by medical oncologists and the surgery that's delivered by surgeons. Sometimes people are a little bit less familiar. Sometimes we get confused with radiologists who read films and scans. Radiation oncology is the use of radiation in the treatment of cancer. And so that's what I do. And I'm delighted to present this trial today, which is essentially looking at the use of surgery and radiation in metastatic HER2 positive breast cancer. This is a trial that's been open now for just a few months. We're very excited about it. It's starting to sort of open in other centers across the country. And so hopefully it will be available to many folks on this call who are interested or may benefit from it. And happy to chat at great length about the science and about why we're doing it and what we hope to learn from this study on behalf of all of you.
That's so great. So, I love that you've explained what radiation there, what radiation oncology is, because people don't know. When actually a lot of people think of radiation as like a scanxiety because they think they're going to get scanned, and that's not a good thing for survivors. So what we're talking about here is HER2 breast cancer, and it's a pretty prominent one. And really, it was a nasty one before we had Herceptin and some of the drugs that we have now, right? It was almost as bad as triple negative. So any other solutions we can have, and I know we were just before we got on the call, I've been talking about it, patients where sometimes the therapies that we have just don't work. And we find that so often with Black women that, just even in not every case, but so many cases where we know we need to do something different. And this is a great clinical trial for these patients. And so can you explain how it works a little bit? Because you're doing radiation therapy and chemo.
Surgery. Yeah, yeah, and the chemo and standard chemotherapy. That's right.
Yeah. So
Yeah,
can you
so
explain like what happens? Yeah.
gladly, and I can share some slides even to help us.
Sure.
Uh,
I'll give you access to slide.
Fantastic. Just some diagrams I think are helpful sometimes for these trials that are a little bit, you know, trickier to all keep in your mind. Hopefully that's visible
I
there.
love
And
the name of it. I love the name of it because it sounds like it's going to work.
that's the
If you,
plan.
right.
You got it. You got it. That's the plan. So you said actually something very important, which is that HER2 positive breast cancer, it used to be the worst, actually. It
Yeah.
used to be even worse than triple negative breast cancer
Yeah.
by virtue of the underlying biology. It was a very aggressive form of malignancy. And then with advances in treatment, we now have very targeted therapies for this very particular subtype of breast cancer. And we'll talk a little bit about why these work and why this trial is sort of an excellent place to look at being a little bit more aggressive in particular because we have these very targeted therapies. So it's called the Archer trial. It's ablation, and ablation refers to radiation, meaning you use a dose of radiation that can destroy the cancer, and resection for the consolidation of oligometastatic. Consolidation means treatment after chemotherapy has basically done its work and reduced the disease to the extent possible. And then oligometastatic, if I go back one slide, oligometastatic refers to having five or fewer metastatic sites. But that's not to say that we're not considering other types of metastatic breast cancer. Just, there's a little bit of nuance here in terms of the exact type of metastatic disease we're looking at, and we'll talk a little bit more of that in a moment.
Okay. So go
So,
back for 1 second.
yes, please.
Consolidation means
Yes.
that means that basically the person has already had chemo to reduce the size of the tumor. Right? I'm just breaking it
Yep.
down a little bit,
The
and
the
then
chem the chemo has started. They've gotten a
yeah.
good amount of chemotherapy. The chemotherapy's done a good amount of work, and then we're trying to come in with some additional therapy to what we call consolidate that benefit that they've gotten from the systemic therapy. That's right.
Great. And then the other big word, oligometastatic, means that you have cancer in more than 5 sites, so more than 5 areas in your body,
It's
right?
actually
So,
the inverse of that. So
oh, the
the
inverse. Okay.
yeah, yeah, the Latin root oligo means sort of small or few. And
Okay, great.
so this is and I'll
Less than
explain all
five.
these parts. Yeah, this
Okay,
is
okay,
we're
okay,
just
great.
on the title slide. We're just getting
Okay, girl,
cooking
I
here.
know. That's why I'm trying to like break it down for the 5-year-olds. Hello,
You're
thank
absolutely
you.
right. No,
Okay,
it's
thank
actually a
you.
really important point, and I'll make this point actually to everyone who's listening, which is that, as physicians and scientists, we're very used to throwing around very large, scary sounding words all day
Yeah,
long. And it is very important to stop people when they're using jargon that you don't understand, particularly in the conduct of your own care. You should be comfortable with all of the vocabulary that's happening. And if something sounds like jargon or is a word you haven't heard, that provider needs to sort of simplify things in a way that you can understand, because ultimately it's your care and you need to understand everything that's going on. So
yeah, we
we're
do
all
that.
guilty of that in
Yeah,
medicine.
yeah. I know we do it all the time, which is why we love our show because I will stop you when we do. And I really do
Please.
encourage our patients to ask the questions. And we always say, you are the CEO of your body, of your health, and you have to, and the doctor works for you. You're the boss.
That's
So if
exactly
you're
right.
not getting the right information, you got to stop and, even when they say we got 15 minutes, you got to say, hold on.
That's right.
Okay, so great. So let's keep going. Thank
Yeah,
you.
so yeah, absolutely. Just one other point about this slide. You'll see here that there's a little logo there at the bottom, the Translational Breast Cancer Research Consortium.
Yes,
This is a group of about a dozen, slightly more than a dozen major cancer centers across the country that are all collaborating together on a series of clinical trials, and this is one of those studies. So while I work at Memorial Sloan Kettering and we have the trial available at my cancer center, and people are flying in for this trial, you may learn that there is, and we can talk at the end about how to find out this information, but you may find that a center near you will have this trial available shortly, making it potentially
great.
more convenient to participate.
Awesome.
Very
Awesome.
good. So the first slide I always like to use for any clinical trial before we jump into anything too deep is just to show you what the trial is, and then we can kind of fill in some of the information after the fact and explain why things are set up as they are. This is what's called the trial schema. This is basically a map of the trial, and any clinician that's involved in clinical trials looks at dozens of these all day long. This is what describes what the trial is and what it's intending to do. So you basically start, it's like a flow sheet. So you start over here on the left, and there are some, there are big jargony words that we
Big
can all break
words.
down,
Yeah,
and stop me if I miss any of them. But it's essentially geared initially to patients who have what we call de novo oligometastatic HER2 positive breast cancer. So HER2 positive breast cancer is a very specific subtype of breast cancer, in contrast to triple negative breast cancer or HER2 negative breast cancer. So we got that. Stage 4 essentially means metastatic, and oligometastatic we talked about being the type of metastatic disease that has 5 or fewer sites of involvement. So if you're listening to this and you're thinking that you might be eligible, but you're not sure how many they counted, or how to count, or do 2 lesions near each other in the same place count as 1 or as 2, just reach out, and that's sort of a determination that we can make clinically. You don't have to stress about that portion of it. And then the other component of this term is de novo. So very particularly for this trial, it's looking for patients who at their first presentation of breast cancer presented with metastatic disease. It's sometimes the case that people present with localized disease. They have surgery, they have radiation, and then years down the road, they come back and unfortunately they have a recurrence with metastatic disease. This is not that scenario is not the type of scenario that's being studied on this trial. This trial is for patients who, at their very first breast cancer diagnosis, a metastasis was identified. And so the reason for that is quite nuanced and relates to the underlying biology of the cancer, but that's the type of cancer that's being studied on this trial.
okay,
So far, so good.
great.
Then the trial is looking to have folks who are within their first year of receiving chemotherapy. So 3 to 12 months of first-line anti-HER2 systemic therapy. Systemic therapy is sort of a synonym for chemotherapy. It just says here per the NCCN, this is a basically a consortium of experts that put guidelines together in terms of what treatments are appropriate and what's the standard of care. So basically, the patients who are eligible for this trial have been on chemotherapy in the neighborhood of between 3 to 12 months. So Within those 3 to 12 months, they've been followed by their doctors and had imaging along the way, sometimes typically every 3 months or so, but we don't mandate how often that is. That's pretty standard, and people are already out there getting that treatment. And provided that they have no progression during that treatment. So here it says partial or complete response. That just means that the tumors have gotten smaller or disappeared on the imaging. That means that everything's working, that this first line systemic therapy is doing its job, and that the disease was sensitive to this first line therapy. So, provided they're now within their first year of treatment, and that's the case, that they don't have any progressive disease, they're then eligible to enroll and receive their random treatment assignment. So there are many types of clinical trials out there that you'll hear about, blinded trials and placebo-controlled trials. This trial is not blinded, meaning that anyone who enrolls knows exactly what treatment they're getting, and there's no placebo on this trial, meaning nobody's getting sugar pill or no treatment. At the very least, what people are getting is if they're assigned to this standard of care arm, they're getting the same treatment as if they didn't enroll on the trial at all. They're getting the most advanced, most up-to-date standard chemotherapy. We're not taking anything away, but by the same token, we're not necessarily adding anything. So this is the group that's sort of designed to represent the current state of the art without anything added by the trial. The second potential randomization treatment, and again, the folks on this trial won't actually get to choose which arm they're on. The trial will decide in a random way so that we can identify the difference between the two groups. But basically, we talked about the standard of care arm, and then the consolidation arm, we talked about that on the title slide. That basically adds in breast surgery as if in the same way that we do breast surgery for stage 1, 2, and 3 disease. That's a lumpectomy when we can do it, or a mastectomy if a lumpectomy is not possible. And then radiation to follow that. And then also radiation to the different metastatic sites. In addition to the standard state-of-the-art chemotherapy that people will be getting in any event, including off of the study, the standard, very effective treatments that people are receiving. So basically,
Hey Doc, I'm
please,
just going to interrupt you for one
of
second.
course.
So basically, we talk a lot about there's no sugar pill. You're going to get standard of care. And normally when you have metastatic disease, you don't have surgery, right? So it's not very often. So that's why this trial is so great, because you now can get surgery. Because I remember even when I was sick, I had stage 3 to begin with. I just wanted the cancer out of my body. We didn't have neoadjuvant treatment back then, but also, the way kind of I break down the understanding of standard of care to our audience is, you get standard care, you get the ice cream, the chocolate syrup, the whipped cream, and the nuts. A great sundae, right? But when the clinical trial, you get the ice cream, the chocolate syrup, the whipped cream, the nuts, and a cherry on top. So what you're offering is, the second arm is the cherry on top. So you're still going to get a great sundae to participate no matter what you would normally get. So
That's right. We're not taking away any of the
right,
effective treatment. Yeah,
right, right.
that's right. That's right. We'll talk a little bit about why we think that the addition of surgery and radiation is important. But in any event, everything else is exactly the same. Very standard, very effective treatment. And then everyone will be followed after the radiation and the surgery are done to see how everyone does. And then the two different groups are compared. And then ideally, if the addition of surgery and radiation has a favorable effect, meaning if that combination of treatments is effective at reducing the risk of a recurrence or prolonging the time that the chemotherapy is working, we'll be able to see that because we'll be monitoring people into the future for a few years to see at what rate do people have any issues from their cancer subsequent to each of these treatments. So that's basically the design of the study. We'll come back to it again a couple of times over the course of the next few slides, but I'll share some background with you as to how we got here. And Ricky, as you exactly mentioned, we don't typically do surgery for metastatic disease. And one important thing to keep in mind is that right now, we have stages 1, 2, 3, and 4. And stage 4 means that at least in breast cancer, means that the cancer has left the breast and the lymph node area. It has arisen somewhere else in the body. But one important thing that scientists and physicians have realized in recent years is that not all stage 4 is the same. Some people have just a few cells that left the area and landed somewhere. Some people might have one metastasis in one spot that's very easy to treat. And some people have very many metastases and have a very challenging situation. So my very first slide is that not all stage 4 is the same. And we use this big word, oligometastasis, to sort of define a bit of a cutoff that we can use to start studying where the differences in stage 4 disease might be. So again, oligometastasis means 5 or fewer, and then not oligometastasis, meaning you could call it, I guess, plain vanilla stage 4 is 6 or more lesions that are metastatic. More importantly, in breast cancer, we also know that not only is not all stage 4 the same, but there's also many different subtypes of breast cancer. And we talked a little bit about the HER2 positive subtype that now has several different types of very targeted treatments that are very highly effective at reducing the rate of progression of this disease. So this is a subtype of breast cancer where the chemotherapy is really, really excellent and very effective. And new agents are coming out all the time, including the latest, which just came out a few months ago and is very effective. And I'll show you some information about that one. So this is one study that now came out almost, half a decade ago, which means that it accrued its patients maybe even closer to 2 decades ago. And what they found for metastatic HER2 positive breast cancer was that when people started this treatment, this is sort of the new standard for this trial. So this is the last generation of trials. Basically, people were getting these two drugs. Trastuzumab is also called Herceptin, and docetaxel is a form of Taxol. And so patients were getting these two agents for a very long time. And this new regimen came out called pertuzumab, trastuzumab, and docetaxel. So basically the addition of pertuzumab or Perjeta, which is another HER2 targeted agent in addition to Herceptin, which is, kind of a miracle drug in the world of oncology. It's really incredible that this exists. It's very effective and it's very targeted to this disease. And so in this trial, they basically compared this new regimen to what was previously the standard of just this one HER2 targeted agent and this one chemotherapy agent. And what they found was that with the addition of the new agent at 8 years, and I'll say one other thing is that we talk a lot about survival, which is one of the most important metrics that we look at when we study any kind of oncology, like how many people are still living after a certain number of years. And so before this new regimen, 8 years after starting the treatment, 23% of people were alive. And after this new regimen was added, 37% were alive. And so that's a pretty substantial increase in the number of people that are still around and still receiving benefit from this regimen. And so that made this regimen actually the standard of care for many, many years. And this is called the THP regimen.
Yeah, and some people may know the combination of Herceptin and Perjeta as Phesgo.
That's exactly right.
Yeah.
Yep, they were
So
marketed as
as
much more convenient dual
yeah,
formulation. That's right.
shorter time for infusion, and yeah, we love our friends at Genentech
There
for
you
making that
go.
happen for us.
I mean, these are very, very effective drugs in the HER2 positive space. So this is a very important sort of landmark clinical trial that basically showed how well people could do after the addition of this new drug. However, one thing that's important to keep in mind is that though 37% of people were alive at 8 years, a substantial proportion still had some disease progression in that time, meaning that they had to change chemotherapy to something that was more effective. What happens sometimes in cancer, unfortunately, is that people start on a very effective treatment, and then over time, the cancer develops what we call resistance. It learns about the treatment and finds ways to evade the treatment and continue to grow despite this otherwise very effective chemotherapy. And so after a certain period of time, that is what we see on with these cancers. With this old regimen, that happened, 10% of people did not have progression after 8 years. But with the new regimen, 16% of people didn't have progression at 8 years, which means still the vast majority of people had progression of some variety, unfortunately, within that 8 year window. So that means, even with this effective regimen, 84% of people had some kind of progression. However, that's not everybody. I mean, 16% of people, if you think about it at a fundamental level, I mean, 10 to 16% of people after 8 years since starting chemotherapy, their scans showed absolutely nothing brewing. And so that starts to raise the question for us as clinicians and for many of our scientist colleagues as well. Do these people really still have any cancer? Why are we continuing their treatment? Could we potentially even stop it? And so there are trials looking at stopping the chemotherapy in this setting and seeing if anything happens. That's obviously, a very new paradigm, a little bit of anxiety associated with that, but that's an interesting clinical trial. But from our standpoint for this trial, what it says is that if for 10 to 16% of people, there's been no progression 8 years after starting treatment, could it be that there were a few people that only progressed because they had a small tumor that we didn't treat, and that's where the resistance came from? And so if we add surgery and radiation and really address the sites that we can see, maybe we can nudge these numbers quite a bit higher and allow far more people to be what we call progression free as long as possible after the treatment's done. So I'll show you the latest. So this was sort of the previous generation of chemotherapy, as I was saying. This is a study that just came out very, very recently. And this is the next iteration of chemotherapy for HER2 positive breast cancer. This is really a mouthful, this drug. This is called trastuzumab deruxtecan, and they added it to the pertuzumab as well. So this is an antibody. It's like Herceptin, but it's Herceptin attached to a chemotherapy drug on the Herceptin itself. And so the Herceptin kind of finds its way to the exact cancer cell that it's looking for. And it drops off an extra chemotherapy molecule right at that spot. And we also add that pertuzumab, which is a HER2 targeted agent. So this trial looked at that THP regimen that we were talking about before and compared it to this new agent, TDXD, plus pertuzumab. And what they showed was that the amount of people that were progression-free went even higher. And so here, a favorite number among physicians and researchers is what's called the median progression-free survival, which is to say, if we find the 50% point where 50% of people were progression-free for longer than this number. And so with THP, that was about 27 months. So 50% of people had no progression for at least 27 months on THP. And with the new regimen, that was almost 41 months. So that's a pretty significant jump as well. And this trial's still early, so it's still collecting more information in the longer term. But when you see these curves, and we don't necessarily have to get into the details of reading these curves, but when you see curves where the lines are very clearly distinct, basically the top line demonstrates a significant benefit to those treatments. And then we're all very enthusiastic about what this means for the future of HER2 positive breast cancer. The chemotherapies are very, very effective. And so now that the chemotherapy is doing such a good job, the real question is, still a lot of people are having progression. Is the progression because they still have a few spots from the very beginning of their treatment that we really should have just taken care of at the very beginning? And then the chemotherapy could kind of clean up the rest and allow them to be progression-free for as long as possible.
That's great.
Very good. So, the question about whether to use surgery and radiation is an interesting one, and it's come up in other diseases as well, not just in breast cancer. And so we're taking a little bit of our cue here from our colleagues who treat other types of cancers where this seems to have worked. Sorry, I just have a little tickle in my throat getting over a bit of a cold here.
Okay. Want to get some water?
Yeah. So the NSCLC is another one of these jargon terms. This is non-small cell lung cancer. This is the most common type of lung cancer. And they basically did the same thing that we're proposing to do here. The standard treatment was just to get chemotherapy for as long as possible. And then these investigators, who are incidentally close colleagues of mine, wanted to add surgery and radiation to see if that would be beneficial. And indeed, it was. So with just chemotherapy, 50% of people lived 17 months or longer.
Wow.
And when you added the radiation and the surgery, 50% of people lived 41 months or longer. So that's a pretty substantial jump. It's actually, more than a doubling of how many people, or not how many people, because the same number of people, but the duration that more than half of the population was still around, basically. And then our colleagues did this in prostate cancer as well. We don't have to get into the weeds about this, but basically, prostate cancer is very commonly treated with anti-testosterone therapy. So that's what ADT is. It's called androgen deprivation therapy. This is sort of like the male equivalent of like tamoxifen and anastrozole and that sort of thing, but targeted specifically at testosterone. And these treatments are very effective for prostate cancer. So here, what they were looking at is how long people, after adding the radiation and the surgery, people could go without needing these medications as a consequence of progression. And so without the radiation and the surgery, people went about 13 months without needing that medication. And then when you added the radiation and the surgery, they went 21 months without, presumably without progression, because that's what would have prompted the initiation of that treatment. So those are two examples, lung cancer and prostate cancer, where this has worked. There was another study that they didn't look at any specific kind of cancer. They looked just at adding radiation to any oligometastatic cancer. And they had breast cancer, colorectal, lung, and prostate all included. And they basically showed a benefit to adding the radiation, regardless of this type of which type of cancer. That improved basically the progression-free survival, and here the overall survival, substantially by treating every one of these metastatic sites.
So, Doc, doesn't it seem almost obvious that by taking the cancer out and doing radiation too would make it better?
It does, a lot of things that seem obvious in the course of clinical oncology end up being a little more nuanced than we thought. So, as an example, to address that very specific point, we're very optimistic that this treatment will work. And in fact, the trial that I'm proposing about adding surgery and radiation in oligometastatic breast cancer, it was actually already done in breast cancer, and it unfortunately didn't work.
Okay, yeah, I'm
Really
thinking,
shocked.
why
Yeah,
aren't we doing this already? You said,
yeah.
right,
So we
what
did, we
happened?
did. We actually did do it already, and we
Okay,
were all stunned that it didn't work. And when we went back to that trial and tried to evaluate why it may not have worked, one of the reasons that we think is that because it looked at all breast cancers together, and there was almost nobody on that study that had HER2 positive breast cancer. And so that's a really important observation because of the first few slides that I showed. We only think that surgery and radiation can work if the chemotherapy can do a lot of the heavy lifting. If it can eradicate any little microscopic cell that's hiding out in the body that we don't yet know about, because we can't operate or radiate something that we can't see. And so really the problem is that there might be little microscopic cells that are invisible to us. And that's what the chemotherapy is designed to
right.
destroy. In HER2 positive breast cancer, we know that the chemotherapy is as effective as anything that's ever been designed in all of oncology. And so we think that's a place where it's most likely to work. That study, again, had a lot of HER2 negative patients and a preponderance of also triple negative breast cancers. And so the chemotherapies there are, while they're effective, they're not as effective as we see in
That's for
HER2
her
positive
too.
breast cancer. So
Got it, got it.
it's a very good question, and it's one that our field has been grappling with, but we're very enthusiastic now about, looking at this very specifically in HER2 positive breast cancer. So
Interesting. So I guess because the effectiveness of these drugs with this cancer. So for
that's exactly
example, like
right.
TNBC,
That's
the
right.
efficacy or the effectiveness isn't as great, isn't as always favorable.
I think
Yeah.
as the treatments are improving also for triple negative breast cancer, there are groups that are interested in studying this question again in triple negative
Yeah.
breast
Maybe
cancer.
with immunotherapy now, not
Exactly.
if it's
That's
doing
exactly
so
right.
better than chemo. Yeah, yeah,
You
yeah, yeah.
got it. That's exactly the point.
Cool, 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 cool.
And so, to summarize sort of the high level questions of this specific trial, it's basically, there's a lot of jargon on this slide and a lot of it looks like it was probably written by lawyers, but we can kind of walk through it in plain English. The objective of the study is to evaluate whether the addition of surgery and radiation improves what we call progression-free survival, meaning improves the duration of time that people live and the duration of time that people live without progression of the cancer, without the cancer getting worse.
Right.
So there are some other things that we're interested in as well, in addition to that are also very important. Um, we want to look at how long can someone stay on their first line of chemotherapy after they've received surgery and radiation. So that's an important thing. How quickly does their physician feel like they need to switch chemotherapy if something has progressed? We're looking very specifically at how long people live. We're looking also at what are the side effects of all of these treatments. That's an important thing to evaluate. Fortunately, for surgery and radiation, these are two treatments that are very, very standard. We use them routinely,
Right.
almost universally in stages 1, 2, and 3. And so we kind of know what to expect in terms of side effects, and we know that they're safe and very effective. In the stage 4 setting, meaning for patients with metastatic disease, they're not often used. And so there's a question about maybe people with metastatic disease have more or even fewer side effects than anticipated. And so we'll be watching that very carefully. And then one other thing we'll be looking at is whether down the road, if people have progression, does that progression occur at areas that we treated with radiation? Or are those areas totally under control and the progression occurs in other sites? That will be important to know as well because it can inform how we choose to do radiation in the future. You'll see in the whole world of clinical trials right now, particularly in breast cancer, very importantly, there's a movement towards looking at something called patient-reported outcomes, meaning it's not just the doctor who gets to say how well things worked and how their patients feel and how well they're doing and how happy they are about this treatment, but now it's become very important to also ask patients how they feel about all of this. And so there will be a series of questionnaires over the course of the trial to see how people feel about these treatments, what they anticipate from the future, what are their side effects that maybe their doctors don't know about or don't necessarily appreciate. And so this is a series of surveys that will be done over the course of the treatment. And then finally, this is a very unique opportunity to study something that many people listening may have heard of. It's called ctDNA, also sometimes called a liquid biopsy,
Yes.
meaning over the course of this treatment, we'll be collecting blood samples to see if we can identify how the cancer is doing as a consequence of the treatment. You know, right now, the main way that we follow a person's trajectory, we follow whether the treatment's working or not, is by scans. And a scan can be a PET scan or a CAT scan or an MRI, many different types of scans that we use. The issue with scans is that by the time a lesion or a tumor has changed in size enough that we can actually visually see it on a scan, that's already many, many millions of cells that have grown or shrunk in order to give us that visual representation of what's happening. This ctDNA or liquid biopsy space is designed to take a blood test and give us a much more sensitive indication of what's happening to the cancer in the body. Is it growing? Is it shrinking? Is it completely gone? Can we not detect it at all? And so this is going to be a very unique trial where we'll be able to potentially demonstrate that these blood tests are actually informative and can tell us who's even most likely to benefit from this sort of treatment of being a little bit more aggressive with the surgery and the radiation.
That
So,
is so great. Can we stop for a second? Because, we hate scans. We have scan anxiety is horrible. And this new ctDNA thing, we've been talking about this a little bit, just getting a blood test, which we're getting our blood taken all the time. So just to know that it's not something that's going to cause us stress to go through the exercise, which a scan does, right? And then you can track what's going on with your cancer.
yeah, right, right.
That's pretty amazing. No, this is just it's great. Just think about just um the understanding that also you're going to listen to the patient and care about how we're feeling through this whole process, which also isn't necessarily the case with a trial or even with any treatment. So very, very cool that that's all part of
Yeah,
it.
I mean, it's really important to understand how our changes to treatment affect the patient's experience of things because,
Yeah,
we could have the most effective treatment in the world, but if we've made you very unhappy with it, then really what good have we done? And so the
yeah,
goal is to demonstrate that we've actually made you quite a bit happier and alleviated some other symptoms and that people are actually satisfied with the types of treatments that are being offered here. And we hope that's the case, but it'll be
yeah,
important to ask that question.
yeah. One other quick thing, and this happened actually a couple of weeks ago. There's this old wives' tale that if you open your body or cut the cancer open or have surgery, that the cells are going to grow and it's going to take over your body. Have you heard that? I mean, I'm sure you've heard that crazy.
I've certainly heard that. I think that there's plenty of evidence to the contrary. Like we
Yeah.
said, in stages one, two, and three, in the absence of surgery, outcomes are very, very bad. With surgery, we cure many of those patients.
Yes. So
So
say that again, because I think there's still this fear that, oh my God, it happened. And it's normally with our older patients, I think it's like an old wives' tale, but people do have this belief that don't cut me because you're going to make it worse. And that is not the case.
You
Not
know,
the case.
the best evidence to that is basically clinical trials of doing surgery and comparing it to not having surgery.
Right.
And, for trials in stages one, two, and three, there is very, very clear evidence that surgery is superior to no surgery.
Right.
That without surgery, unfortunately, many patients ultimately succumb to the breast cancer. And with surgery, we're able to cure a very, very large proportion of those patients.
Yeah. That's awesome. That's
Yeah.
awesome.
I'll go
Yeah.
back just to one other thing about the ctDNA and the blood tests. It's still a very early time in this field. And as much as we would like to replace imaging with these blood tests, I don't think we're quite there yet. We still need to prove that they're as effective as the imaging, that they're as reliable. And this is why we've added this component
Yeah.
to this particular trial. This will hopefully help us get there in the future. But right now, in our clinics and sort of really in any form of breast cancer, it's really hard to replace imaging because we understand it very well and it gives us a lot of very important information. Maybe one day these blood tests will replace the imaging, but not quite yet.
Yeah. But it's a great thing, great to be in progress,
Yeah, absolutely.
Yeah.
So, just to summarize again, who's eligible for this trial? So it's anyone over 18 years old. Believe it or not, there are men who are afflicted with this sort
Oh,
of
yeah.
presentation as well. It's not common, but they're out there. And we talked about what de novo oligometastatic breast cancer means. So five or fewer sites. It's got to be the HER2 positive type of breast cancer. And the typical patient for this study will still be within their first year of starting chemotherapy. Folks who are, 5 years out from starting chemotherapy, unfortunately, won't be eligible for this study. This is for people who are kind of just getting started within the first year.
And which we really encourage patients now, please call us when you get diagnosed. Because there's a trial like this and many others should be part of your original treatment options. It shouldn't be, you should be considering something like this right from the beginning of your diagnosis. And we talk about that a lot, Doc,
Yeah.
to help people know that, this is a great thing to have right when you start, right when you get diagnosed. Don't
Yeah.
wait.
I mean, I'm asked frequently, when is a good time to ask about clinical trials? And the answer is sort of there's no exact time. It's sort of all along at any time. There are trials that are designed just for people who are getting started out, like this trial. There are
Yeah.
plenty of trials that are for people who are further along, several years out. Maybe they're already on their second or third type of chemotherapy. So there are trials all along, and the typical point at which a new trial is considered is often when treatments are being changed. That's the most common place where people start looking for trials, but you can never start looking too early.
Never.
And ask your care team and
Yeah.
reach out to great organizations like this one, and they'll have information for you about what's coming online, what's available. And the other place to get clinical trial information is a second opinion. If your team doesn't
Yes.
necessarily have access to very many, or it seems like they have a limited portfolio that they're presenting to you, you can look at, your nearest major cancer center or reach out to our cancer center and we'll be happy to direct you accordingly. There's also a website called clinicaltrials.gov. It's a very,
We hate that place.
yeah, it's not the most user-friendly website. This is true.
But
And
we actually have our own website where we pull the breast cancer trials into it. Dr. Bronstein, it's called whenwetrial.org. And and so basically we sort of put a hug around the science. And so you can go in through our portal, put in your information, and it will pull the trial from there as
that's
well. Much
fantastic.
easier to navigate.
That's fantastic. Yeah.
And we send our women there too, because it's got all the trials and we can even, show people how to do it and help them
Yeah. That
process.
sounds like a very useful resource. The
We have
reason
a navigator. Yeah,
I,
navigator.
I brought up clinicaltrials.gov to say two things about it. One is that it's very, very comprehensive in terms of the names and which trials are available,
Right,
but it's not very comprehensive in terms of all the details of the trials and which are
right.
still open and often what you have to do in order to participate. So it sort of gives you the entire 30,000 foot view of everything that's going on in research, but it's a little bit challenging to navigate, and it's not always the most straightforward to understand if it applies to a particular scenario or what kind of patients they're looking for.
Yeah,
So all that to say, I put our little trial map back on the page if anyone's interested, and I left my contact information down there at the bottom left. And feel free to reach out if this sounds of interest, or you're not sure, reach out and we'd be happy to chat about it and see if this might be something beneficial, or if we have any other trials that might be related that might be beneficial.
great, great. And I'm putting your email in the Facebook comment so people can have access to it. And then,
Terrific.
and everybody knows they can kind of reach out to me and
Great.
will help. But this is such great information. It seems like a no-brainer to me, you know what I mean? Like it's just, we're doing so many treatments and just think about you're doing something that could help yourself, your own cancer, but also help the community, help us learn more about bodies and how these things work. And we encourage it so much for Black women, to have, actually, I think I should get your email address, to have access to this science, this science that could make such a difference for you and your cancer. And this
This
one
this is
seems
why we're
pretty
pursuing this
easy,
work. That's the exact
pretty
reason.
easy. Like there's no side effects like we get from other stuff from surgery and radiation. We're so used to having all the other things, right?
Well, it's
Oh,
not
you're
to say
gonna
there are
get the
no there.
chemo.
It's not that there are no side effects from surgery and
Right.
radiation, but
Right.
we do know that they're very well tolerated because we've had, nearly a century, maybe even more than a century at this point to refine those two treatments. So the side effects are more time limited and typically localized in comparison to different kinds of chemotherapy drugs.
Right.
Typically, they don't make you sick, they don't affect your hair, people don't get nauseated from surgery and radiation. But,
Right.
surgery has some healing associated with it, and radiation has some local irritation associated with it. But typically, we can manage those and people recover quite nicely.
Great. 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 Well, thank you for this.
Thank
Want to
you.
so we can see your beautiful face. Um, we are grateful for you being here on a Sunday with us and happy to share this really, really vital information. And hope that some people will take heed. And you guys know how to reach us, and you have Dr. Bronstein's email address. And follow up if you're interested. And we will keep posting this. We'll post it on our social media. We'll post the episode. We'll also post about the trial. And I think I have some information from you guys about the trial, but I'll get it, get a flyer or whatever.
Absolutely.
And we'll continue to talk about it. So thank you, thank you, thank you.
Well,
If
that's
Dr.
terrific.
Mo were here, she would say, we hope this episode was reliable, relatable, and real. And we're grateful to you for everything that you're doing. Thank you so much for the science. We don't have enough of it. Our mission is to advance science for Black women. So very grateful.
Absolutely my pleasure. Thanks so much, Ricky, for spending part of your Sunday with me.
That's okay. You too. You too. Blessed you love. You have to say blessed you love. Take care.
Take care. Bye bye,
Take care.
everybody.
Bye-bye. Bye-bye. Take care. Thank you so much.